Welcome back to It's Your Case, presented by VetCT.com. I'm Heather Chalmers, your radiologist on demand for this week. Here we have a 9-year-old miniature poodle with occasional cough. She actually presented for lameness, which was thought to be due to luxating patella, and thoracic radiographs were elected because during the history taking process, occasional cough was identified by the owner. Now, we've become thorax experts over the last few weeks, so maybe many of you will have looked at these and already kind of landed in a similar place to me. That overall, although the pulmonary inflation is not perfect, and there's probably a little bit of motion artifact obscuring some of the blood vessels, especially on this VD view, overall I would conclude that the heart and lungs are fairly normal in this case. I can see the pulmonary blood vessels quite well. For example, on the left lateral view, I can see the cranial vessels here all the way to the periphery of the lung. And in fact, I see the artery bronchus vein of both of the cranial lung lobes. You can see that the artery bronchus vein here, the more ventral located one, is slightly larger than this, the more dorsally located one. This is because the dorsal one here is in the left cranial lung lobe, and on the left lateral view will be less magnified than those to the right cranial lung lobe. So let's talk about something other than heart and lungs. In a coughing miniature poodle, many of you may have thought about the trachea. I'm showing here at the thoracic inlet an area where there's an increased opacity in the dorsal tracheal region. What do we do when we see this on radiographs? Well, this is somewhat of a complicated situation because although this can be a radiographic finding in collapsing trachea, it can also be created by several mimics which are not necessarily of clinical concern. Let's go back to the left lateral view simply because it shows more of the trachea for us to look at. Here we can see that when I trace the tracheal gas shadow, you can see that there's this ventral concave bowing soft tissue opacity, giving us somewhat the impression of tracheal narrowing right at the thoracic inlet. I can also still very faintly trace a little bit of trachea dorsally, as you can see here and here. So some tracheal visibility is possible in this case simply because there's faint mineralization. So how do we interpret this area in between? There's clearly reduced tracheal gas opacity. We see it on both lateral views, here on the right lateral view as well. I would say that it's about 50% narrowing or possibly even more so. Two things mainly that we want to think about that can contribute to this. One of them is generally incidental, and that's redundant dorsal tracheal membrane or trachealis muscle. So in dogs and cats, we have incomplete tracheal rings, and we can see that the dorsal aspect anatomically is comprised of a dorsal tracheal membrane or trachealis muscle. That can be sort of flaccid or flop down into the trachea, especially in the cervical region where the trachea is surrounded by soft tissues, and those soft tissues can have sort of an impact. This can also be affected by positioning of the head and neck. So redundant tracheal membrane is something I would definitely think about for this case, especially because I can see maybe a hint, I'll go back to the other lateral view, maybe a hint of tracheal rings kind of still standing here above that soft tissue opacity. The next thing, of course, we have to consider is true tracheal collapse due to chondromalacia. In the case of tracheal collapse, the tracheal narrowing is not because of sort of incidental redundancy of that membrane, but is actually due to inability of the tracheal rings to maintain their normal rigidity due to some type of chondromalacia. Tracheal collapse can be graded using endoscopy. We can also assess tracheal collapse if needed with fluoroscopy. The advantages of fluoroscopy, or I suppose what it offers, would be we could assess the entire trachea during inspiration and expiration. The reason that this is relevant is that the portion of the trachea that collapses will differ during inspiration and expiration. So looking at the trachea dynamically will allow us to see whether there is truly a collapse, whether it's happening during inspiration, expiration, or both, whether it's located in the cervical, thoracic region. And then lastly, we're always interested in the status. Whenever we think we have chondromalacia, we're always interested in the status of the mainstem bronchi. The mainstem bronchi, for example, in this case, is going to be just caudal to the carina. So you can see we have a nice wide open mainstem bronchus here. Mainstem bronchial narrowing can accompany true tracheal collapse in dogs and is something that can affect the treatment plan. So here's a case where my overall conclusion would be I'm comfortable that there's no radiographic pathology of the heart and lungs, and there's a finding of the trachea that could certainly be a normal anatomic variant due to that redundant trachealis muscle, maybe even superimposition of soft tissues in this area, and specifically the longus coli can also contribute. But especially given that we have a mini poodle and we have occasional cough, we should rule out tracheal collapse. This can be done quite simply by asking more historical questions about the cough, or even during physical exam, trying to elicit a cough with tracheal palpation. More advanced imaging techniques could be considered if indicated, and that could include fluoroscopy or tracheoscopy. Fluoroscopy, as they said, is really helpful. We can measure the percent narrowing and assess how much of the length of the trachea is affected, as well as get a grasp on the status of the mainstem bronchi. So be sure to review the full report associated with this case and join us next week as we look at another aspect of the mediastinum. Thanks for listening, and remember, it's your case, so please post any questions on social media.